Assalamu alaikum everybody again. This is actually the lecture about peripheral neuropathy. So as you know, the peripheral nerve contain bundles of both, myelinated and unmyelinated fibers. As you can see here, can you see? Let's put my options. Okay. Can you see my cursor, the pointer?
Yes, we can see it.
Okay. All right, so the top left image here, as you can see, have both, myelinated and unmyelinated fibers. This is actually an image that is done using toluidine blue, which stain collagen. And it shows a cross-section of a nerve, okay, that contains both myelinated and unmyelinated nerve fibers. Now, the dark rings, as you can see here, the dark rings are the myelinated fiber. Okay, so the dark part, the dark, circle, if you will, is the myelin sheath. Now, the white in these rings, the white material, the central white material, is actually the axons. Now, the unmyelinated fibers are not clear at this resolution, and you need higher resolution to see it. There is also the fibrous capsule that surrounds everything, that hold the peripheral nerve in its confines. Now, the top right image here, show a myelinated peripheral nerve fiber. All right, so myelinated peripheral nerve fiber. You can see that, the myelin sheath is very thick, okay? All right, and you can see that actually the myelin fiber, the myelinated, nerve fiber is embedded in the Schwann cell, okay? So there is a very strong relationship between the plasma membrane of the Schwann cell and the myelin sheath, okay? So the myelin sheath in the peripheral nervous system is derived from the plasma membrane of the Schwann cell. In case of injury, plasma membrane of the Schwann cell will take care of, giving rise to the myelin sheath that got damaged, okay? As long as the Schwann cell is intact, recovery from demyelinating episodes or attacks is going to be fast and complete. Now, in the central nervous system, the myelin sheath is given or is provided by the oligodendroglial cells. So different sources for the myelin sheath between the PNS and the CNS. All right, so the bottom left image that you can see here, it's an electron microscopic image of a peripheral nerve showing myelinated and unmyelinated axons. So these are the myelinated, these are the unmyelinated using an electron microscope. Now the bottom right image shows a longitudinal section of a peripheral nerve fiber. Notice here that the myelin sheath is not continuous. As you can see, there are interruptions in the myelin sheath along the entire length of the axon. This is going to ensure the conduction velocity. So there is periodic loss, normal periodic loss of myelin sheath at the Ranvier nodes. And the jumping or saltatory conduction happens through the nodes of Ranvier. And that's going to result in faster conduction than in a continuous longitudinal fashion. You can see that this is, what we have talked about, and that's going to be listed in words as opposed to images. All right, so now what are the basic reactions seen in peripheral neuropathy? Top right is actually the normal nerve, and you can see here, this is the neuronal body, and here is the neuromuscular junction, and between them is the axon, that is embedded in the myelin sheath. Okay, now the first basic reaction or basic changes that you see in peripheral neuropathy is what is known as the Wallerian degeneration. All right, so with Wallerian degeneration, it occurs when the axon is transected, as you can see here. This could be due to a cut, this could be due to an infarct, maybe cooling, any kind of physical injury that is going to damage the peripheral nerve proximally. The end result is that the proximal part will stay intact. Okay, so the proximal part, the neuronal body and the nerve, and the proximal stump, if you will stay intact, but the distal, part, the distal to the site of injury, the axon and the myelin sheath will undergo degeneration and become disintegrated. Okay, as you can see here, they have disintegrated, and that disintegration is going to be morphologic and chemical, and consequently, due to the denervation of the muscle, because there is no longer denervation of the muscle as a result of that physical, event, if you will, the muscle itself will also undergo atrophy. Okay. Could there be a recovery from this? Yes, the recovery starts from the neuronal body. How do you know that? Because then, in this case, the neuronal body is usually filled with this blue granules known as the Nissel's granules. So these Nissel's granules are the rough endoplasmic reticulum. In Wallerian degenerations affecting the neuronal body, you're going to be seeing that the endoplasmic, the rough endoplasmic reticulum granules are no longer there. They become part of the cytoplasm. They disperse and become part of the cytoplasm of this neuronal body. The neuronal body here is not degenerating; rather, actually, it is regenerating. So the neuronal body here is not degenerating, it is regenerating in a process known as central chromatolysis. In this case, what happened is that, the cell is revving up its engine in order to produce nutrients and substances that are important, in regeneration of the peripheral nerve from the intact proximal stump. That is what is known as the central chromatolysis. So remember, central chromatolysis is a sign of regeneration. All right, so the next one is going to be the segmental demyelination. Segmental demyelination is going to be characterized by damage to the myelin sheath itself, as you can see. So the axon is intact, but the myelin sheath surrounding it could be either focally damaged or much more than the focus. Sometimes, full segment, full section. So sometimes the full length of the nerve could be damaged. All right, so how does it happen? Usually happening by an autoimmune response that usually is directed against the myelin, okay? So the axon stays intact, conduction in the muscle is still happening, but because you no longer have a sheath, the myelin sheath is becoming slower. But there will be no muscle atrophy because the conduction is still happening. You can see that the muscles are still here intact. Okay, because because again the conduction is happening. Now another feature of segmental demyelination is that if it is spotty, if it's focal, the damage will happen very fast, but also the recovery is going to happen very fast. However, if the loss of myelin happens over a long part of the myelin of the peripheral nerve, then the conduction will be blocked altogether. So there will be recovery if the Schwann cell that gives the myelin, okay, are intact. All right, so if the Schwann cells are intact, the recovery will be complete. Injury and recovery from this process is going to be taking about a few hours to a few days. All right, it's going to be faster than what you see with Wallerian degeneration. Guys, 1 second, please. All right, so All right. Now the final one, which is, I'm sorry about that. I cannot really fix. I cannot put it up. Okay, but you will get the idea. The final one, the final reaction, if you will, is going to be the distal axonopathy right here. Distal axonopathy, the name itself gives it away. The damage happens distally. Okay. So, like Wallerian degeneration, it involves degeneration of both the myelin and also the axon. Now, the difference is that this is going to happen distally and spread proximally. Okay, so this is the starting point, and as time goes by, the degeneration is going to spread proximally. Now, the origin of this process is that the neuronal body that could not maintain metabolic needs of the peripheral nerve, especially in its distal part. So as a result of that, you can see that the muscle also has degenerated, has undergone atrophy. Now, this chain of events is similar to what you see following occlusion of a coronary artery. If you recall from the POD, the areas affected first are the most distal to the occlusion. Okay, so I remember that famous picture in the POD, if you guys still recall it. So even though here you still see actually central chromatolysis happening, and you would hope that this is going to take care of business and deliver the goods to the distal part, but here the process to start with is a disease of the neuronal body, and this explains why the pace of the disease is slow and the recovery is slower and incomplete. So in terms of recovery after the injury, the best and the fastest kind of recovery is going to be with segmental demyelination. That's going to be followed by Wallerian degeneration. And third last is going to be the distal axonopathy. Unfortunately, distal axonopathy is the most common among those reactions. So in Wallerian degeneration, as long as the fibrous capsule of the peripheral nerve is intact, the regeneration of the proximal stem is going to happen along this fibrous capsule in a way that it will be guiding it towards the muscle. So that's going to result in full recovery. Okay. In a lot of instances, the fibrous capsule is going to itself to become also disintegrated and degenerated with the rest of the nerve. So when the proximal stump will start to regenerate, it won't regenerate longitudinally, it will start to regenerate haphazardly, creating what you call a neuroma. Right? So the neuronal the neuronal cells will be going in all different directions, but not towards the muscle, as there is no guiding structure taking it to the muscle. Right? We will see an example of a neuroma in the next few slides. All right, so this is it. All right, now, with Wallerian degeneration. So Wallerian degeneration, as we have talked, occurs secondary to what may be considered axotomy, transection of the axon. And we also mentioned the causes, including trauma, cooling, infarction, that is infarction to the vessel supplying the peripheral nerve, and other physical injuries of the peripheral nerve. And the result is complete disintegration of the myelin sheath and the axon. Now look at this disintegration right here in these pictures. So the bottom right, the bottom right image here, when we do myelin stain, the silver stain that is to be picked up by the myelin, here you no longer see the continuous longitudinal intact fibers. Rather, we are seeing bits and pieces of these myelin fibers showing degeneration. So it has lost its structural integrity. Okay. Now in the top one, this is stained with oil red O. Oil red O stains fat. So you can see here that the fat stain will be picked up by the degenerated myelin particles. Okay. So when we talk about, again, just to drive the point home, central chromatolysis, even though the name itself with the suffix lysis may indicate degeneration, it's not degeneration. It is regeneration. Remember that. Yeah. All right. So this is the neuroma that we have talked about that you see with the that you may see with the Wallerian degeneration. That's actually when the fibrous capsule itself becomes damaged. So with the toluidine blue, which is stained collagen, the neuroma, you can see here that the neuroma is a mix of fibrous, tissue and neural ends that lost, direction and starts to actually, get arranged haphazardly, creating this, painful, if you will, nodule or, bump. All right. Now, distal axonopathy, we have talked about that again. So, distal axonopathy usually is bilateral and symmetrical. Also, it goes by the name of axonal dystrophy. So, distal axonopathy, axonal dystrophy, they pretty much are the same. They talk about the same. And as they are more severe, distally, that's going to result in what is known as a stocking glove sensory loss and weakness. That's what you see in diabetics. So distal axonopathy is a neuronal body dysfunction when the metabolic needs of the neuronal body, especially in its most distal part, are no longer met. Okay. And the first changes appear in the most distal part, but then it spread actually proximally. All right. All right, so this is the segmental demyelination of myelin loss in the peripheral nerve. The end result is going to be slowing the conduction, or if it is vast or complete, actually, loss of the myelin sheath, then you're going to All right. So I'm sorry about that. Can you guys hear me?
Yeah, we can hear you.
All right, good. Clearly, is my voice clear?
Yes, it's clear.
All right, thank you. All right, so now we're talking about actually segmental demyelination. So it could be spotty or could be, involving vast regions of loss of myelin in the peripheral nerve. The end result is going to be slow conduction or a complete block of the conduction in case of large areas that have lost its myelin. Either way, recovery will happen in these patients as long as the myelin, as long as the Schwann cells are intact. So, and also as long as the axons and the neuromuscular junction are there and are, sorry, just 1 second. That's gonna be are there and are intact. Then actually, what's going to happen is that the muscle is not going to undergo atrophy. Okay. And here you see that actually from this reaction, from this picture, that the neuronal body did not really undergo central chromatolysis because it is not where the recovery would happen from. Recovery would happen from the Schwann cell here. Okay, and the recovery will happen from the Schwann cell in a plasma membrane, if you recall. So the Schwann cells, if the Schwann cells are spared and are fine, then repair the remyelination, that's really the kind of repair that will occur. And the repair from segmental neuropathy is more complete and rapid than from Wallerian degeneration. All right, so the upper left picture is, this is going to showing you the normal, fully myelinated axons. Now, the upper right picture, that's actually what is seen in autoimmune injury when you see complete loss of the myelin versus the start of regeneration of the myelin. And all these dark actually dots that you see are myelin that have not formed a circular pattern around the axons yet. So it is in the process of doing so. Now, the bottom left image, here you see a thin rim of myelin sheath. In autoimmune damage, usually the damage happens in recurrent waves. So you will see first injury happen, then you will see recovery, then injury, then recovery. So when the injury happens, the myelin is lost. Then the myelin is going to be reconstituted and is going to be covered by a fibrous capsule. Then a second actually injury comes. Before, the first layer of, before the first, wave, if you will, has recovered completely. So you will start to see that there will be myelin that is going to be getting deposited on top of the fibrous capsule, of the first recovery. And then there is another fibrous capsule on top of the second, myelin layer, and so on and so forth. As a result of that, you're going to be seeing that, the peripheral nerves will become very thickened, as you can see. Hypertrophic change of the peripheral nerve that happens in autoimmune attacks of the peripheral nerve. What happens in this kind of reaction in segmental demyelination. Now, in the bottom right image, you can see actually what is known as temporal heterogeneity, because you see lesions of different ages in the same picture. And this image shows recovery from demyelination episodes. All right, so this image here shows recovery, full recovery, sometimes partial recovery, and the damage that happens at one point in time. So in the left lower quadrant, there is this what looks normal, completely normal, thick intact myelin sheath, as you can see here and here. Okay, these are either fully recovered or it may not have been affected in the first place. Now, in the right upper quadrant, Okay, right upper quadrant, the exact opposite, you see that there is a thin cuff of myelin sheath. So these are, these are fibers on their way to become fully, surrounded by a myelin sheath and, by a thick myelin sheath eventually. So this myelin sheath is in the process of getting formed, and on its way to recovery. Now, in the left upper quadrant, you're seeing that there is, unmyelinated fiber. It does not have anything surrounding it here. Okay. So segmental demyelination is less common than distal axonopathy, which is the most common form, unfortunately. However, segmental demyelination is an important neuropathy, particularly with inflammatory demyelinating neuropathy and genetic metabolic neuropathy, such as the CMT disease that we will see in a second. All right, so this is some epidemiology. And, what do you see in diabetes or diabetics? You see actually two types. The most common type is going to be distal axonopathy. But demyelinating neuropathy may also happen. Now, in CMT disease, which is known as Charcot-Marie Tooth disease, which is an autosomal dominant condition, the most common hereditary neuropathy with an incidence that is about 15 to 20 in 100,000 cases. And it develops or as a result of a mutation of a gene known as the PMP gene, and presents with polyneuropathy. So what does this gene do? The PMP gene provides instructions for making a protein called peripheral myelin protein 22, PMP 22. This is where the name came from. So this protein is found in the peripheral nervous system, and it helps actually in the detection of the touch, pain, heat, and sound. So in this case, when it becomes, mutated, that's gonna, again, make the patients, lose this kind of, senses. All right, there's also the GBS, another important, epidemiologic point when it comes to peripheral neuropathy, the Guillain-Barré syndrome, which is the most common demyelinating polyneuropathy. It's a medical emergency because it may kill the patient if the patient is not supported, in their respiration, because usually it involves the respiratory muscle, and the result may result in respiratory paralysis, paralysis of the diaphragm. So prompt recognition and intervention with the respiratory support are very important. All right, so how to deal with the patient presenting with this condition? So for one question to ask about, is there a disease or not? Is there a neuropathy or not? So peripheral nerve, carries both sensory and motor function. So that's why we see actually a mix of the two, deficiencies. Sometimes we may see actually pure motor disorder with peripheral neuropathy, such as with Guillain-Barré syndrome. But for the most part, patients presenting with peripheral neuropathy will present with weakness and atrophic muscle, and also sensory loss or abnormalities such as pain, pins, needles, paresthesia, weak, absent tendon reflexes will be present as well. We have to ask the patient about family history. If the family history is positive, then we can think, that may open the door for, a genetic disease that may result in peripheral neuropathy. The second thing that you're going to ask about, what kind of neuropathy is it? So most commonly it is symmetrical polyneuropathy, and which is usually divided between axonopathy and demyelinating, disorder. So the distal axonopathy, and the demyelinating disorder. The distal axonopathy is going to be caused by diabetes, toxins, or drugs. Demyelinating disorders, for the most part, will happen actually by autoimmune disease. Another question, is it axonal or demyelinating neuropathy? Is it involving the axon or the myelin sheath? And most of the neuropathies, again, unfortunately, are axonal. So mostly are going to be distal axonopathy versus Wallerian degeneration. Axonal are involved in a slower pace of, kind of recovery, and the disease will happen over actually a very long period of time. Recovery will almost always be incomplete, especially with the distal axonopathy, because there is neuronal body disease that result in the distal loss of axon and myelin sheath. Now, demyelination, as I mentioned to you, quick, damage and quick recovery, quick process of injury that revolves, around few hours to few days. It's going to be followed by quick recovery as long as, the Schwann cell, especially its plasma membrane, is intact. We may do some labs. We may do some labs, such as, nerve conduction study. If that is done, you will see that in demyelinating neuropathy, there will be slow or blocked conduction velocity. In axonopathy, you're going to be seeing that there is a low action potential amplitude. Now, another question, is it active or burned out? That's an important one. And what is the cause, as we will see in a second. All right, so we've gone over this. Now, right, so some of the studies, let's talk about some of this, because we talked about most of this here. Now, some of the other studies, so we already talked about this as well, but I don't see the, sorry guys, once again. Where is the EMG? Sorry about that. All right, we'll talk about it even if it's not here. Okay, so the electrophysiologic studies are recommended if the diagnosis remains uncertain or unclear. After doing the initial diagnostic testing, the simple blood test, the CBC, metabolic profile, CSF analysis, etc., you may actually go on to, and of course, before that, the careful history and the physical exam, we may go and, do two primary types of electrodiagnostic studies: the nerve conduction studies that we have just mentioned, but also the electromyography, the EMG. So with the nerve conduction studies, that may aid whether the neuropathy is axonal or demyelinating or both. Okay, the axonal loss leads to lower amplitude, so that was mentioned, and demyelination will cause prolonged latency and slow conduction velocity. All right, so another point actually to be made here is it mononeuropathy or polyneuropathy? That's an important, distinction that is going to help you, also narrow down the diagnosis that, about the, kind of injury, to reach out at least a cause of what is happening. So, is it mononeuropathy versus polyneuropathy? Is it a single nerve versus diffuse, kind of polyneuropathy? So also symmetrical polyneuropathy is much more common than single nerve involvement. Okay. So the mononeuropathy will affect a single nerve or a few nerves asymmetrically, and usually it's axonal in nature, and mostly caused by vasculitis. That's actually what's going to give it out. The fact that it is either a single nerve or a few nerves asymmetrically. The word is asymmetrically, and axonal in nature, and that's going to be mostly caused by vasculitis. Polyneuropathy, on the other hand, the symmetrical polyneuropathy, are either going to be axonal, usually secondary to diabetes, toxins, or drugs, or it's going to be demyelinating, most commonly from immune-mediated acute inflammatory demyelination of the peripheral nerve. So what you call the acute de-inflammatory demyelinating polyneuropathy, also known as IDEM. Is the condition acute versus chronic? That's also going to cause it. I mean, when it comes to acute, usually that's going to be either GBS, most commonly, far more common than anything else, versus vasculitis. Chronic, most other neuropathies are chronic. So GBS and vasculitis are going to be falling under the acute category here. All right. So also the physical exam is going to distinguish the clinical exam will distinguish for you between large versus small axons. Why is that the case? Because usually large axons are involved in motor function as well as conveying modalities of vibration and proprioception, whereas small axons mediate pain, temperature, sensation, and autonomic dysfunction. So for this reason, neuropathy of large axons, you see weakness, loss of vibration, and sense of position, what's known as proprioception. Whereas involvement of the small axons, there's going to be a loss of pain and temperature sensation. So there will be anterolateral system modalities and also autonomic dysfunction. These latter ones, usually are specifically severe when it comes to patients with diabetes. Causes. If you say diabetes, you will always be right. As you can see here, it is top of the list. And it's a polyneuropathy, the diabetes that is, polyneuropathy, axonal neuropathy, most commonly, but demyelination may also happen with it. And it is the most common disease presenting with neuropathy. Now, there are other diseases as well, such as uremia, sarcoidosis, eczema, and others. Now, there is also a long list of carcinomas that may actually cause that. Carcinomas, myelomas, cryoglobinemias. How does it do it? So usually, when it comes to polyneuropathy, it's not that malignant tumors are invading the nerve. Now, they may do this and they will result in pain and all that stuff, but usually the neuropathy in this case are produced by peptides that are being made by these tumors, and these peptides are going to get deposited in these peripheral nerves, causing what is known as a paraneoplastic syndrome. This is something that you guys have discussed in the POD. Right, so example of that, myeloma. So myeloma and other, plasma cell dyscrasias, produce abnormal amounts of immunoglobulin chains that is going to get, processed into amyloid, and the amyloid will get deposited in the peripheral nerve, resulting in peripheral neuropathy. Also, some plasma cell tumors produce antibody directed against the BMP, the basic myeloid protein. So it has what you call an autoimmune component to it. So destruction by demyelination, so resulting also in peripheral neuropathy. Also, plasma cell dysproteinemias may cause vasculitis, and vasculitis will cause, axonopathy and Wallerian degeneration. So there's a couple of mechanisms in which, in this case, myeloma and its related disorders of plasma cell dyscrasias may end up actually causing peripheral neuropathies, as we have talked about. Now, some infection may result in neuropathy. Some of these infections may be related to a direct invasion of the nerves, such as, what you see with AIDS and other, conditions listed, including, for example, Borrelia burgdorferi. You remember that, the Lyme disease, bug that causes Lyme disease. So there is direct invasion of the peripheral nerves. Herpes zoster may result also in direct invasion of the peripheral nerve, and then it will actually move on to become latent. Now, in the AIDS patient, towards the end of the HIV, phase, that is before the patients, get into the AIDS, the full-blown AIDS, syndrome, you have a very low number of CD4. As a result of that, those patients will start to have actually, direct invasion of the HIV viruses in the dorsal root ganglia, resulting in peripheral neuropathy. So the AIDS is very powerful in its ability to produce peripheral neuropathy, as patients with HIV receive antiretroviral medication, and a lot of these medications themselves have side effects of causing peripheral neuropathy. And you may also, towards the end of the HIV, disease, again, before they go into full-blown AIDS, we may see development of vasculitis, and also, that, with the dipping number of CD4 cells, CD4 T cells, you may start to see that the patient is developing opportunistic infection, such as CMV, cytomegaloviral infection, mycobacterial avium intracellular, that may actually go into the peripheral nerve, causing peripheral neuropathies. As you can see, there's a long list of diseases that cause it. There is actually toxins, alcoholism, there's vitamin deficiency, compression disorders, and so on and so forth. A couple of words about inherited neuropathies such as the CMT disease, the Charcot-Marie Tooth disease, group of inherited conditions that damage the peripheral nerve. We talked about, the PMP gene and, how is that related to it. What's important when it comes to inherited neuropathy? The most important, the first step is going to be the family history. So you don't miss that when you are seeing a patient presenting with, a peripheral neuropathy, if there is a family history or not. All right, so how to approach a patient with peripheral neuropathy? History taking is going to be very important. So this is going to tell you if the disease is sensory, motor, or a mix. If it's pure motor, then, if it's a pure motor kind of presentation, then GBS should be high on the list of differentials. Physical exam will also tell you if it's large or small. Is it going to be axonopathy or demyelination? Is it mononeuropathy versus polyneuropathy? Now, lab studies are going to be important as well. So in this case, nerve conduction studies, which is an electric current that is applied to nerve and muscle, and the reaction of that nerve is recorded. We talked about that a minute ago with the demyelination. You see that there is a decrease or a block in nerve conduction velocity. With axonal, a kind of damage, you see decreased amplitude. We may also do muscle enzymes, such as, CK, creatinine kinase, and amylase. If, the levels are very high, we may actually suspect muscle disease than neuropathy. Why do you look for very high levels as opposed to simply an elevated level of CK and amylase? Because even in other disease than muscle, meaning even when the disease itself is a neural disease rather than a muscular disease, there may be slight elevation of the CK and amylase coming from the muscle. So unless it is what you call a very dominant rise of CK and amylase, then it should not be considered as related to muscle. We may do CSF analysis. This is actually looking for the oligoclonal bands, such as what we see, in GBS. CSF this is the oligoclonal band is with the, one second, please. It's a demyelinating disorder. The word will come in a second, don't worry. All right, but you may also do it, you may do CSF analysis, looking for high protein in GBS, in Guillain-Barré syndrome, okay? If everything fails, then a nerve biopsy is going to be, or may actually be helpful. Kept as a last resort, because most of the time what you're going to get is, you're going to get an end stage kind of, nerve fragment that's not going to tell you what caused actually the neuropathy to start with. All right, so here is actually the nerve biopsy. Nerve biopsy is going to be taken from the sural nerve, which passes posteriorly to the lateral malleus. So this is the lateral malleus, this is the sural nerve. So once the biopsy is taken, which is going to be a superficial biopsy, is going to result in an area of a loss of sensation and an area of high anesthesia. So the biopsy is processed for light electron microscope studies. So the neurobiopsy may answer, some questions about peripheral neuropathy. It will not pin down the final cause because most peripheral neuropathies have a very specific pathological features, making it hard to determine what's causing the neuropathy. Now, this is what you see with diabetes, diabetic neuropathy. You see complete loss of myelin, as you can see here in this solid in blue. All right, so complete loss of myelin in nerve fiber in diabetic patient compare with normal. Look at the normal inset here. So in this picture, we see that we are looking at a section of abnormal nerve fiber of a patient with diabetes have lost all the myelin, and by the time you see this, those patients would have most likely developed retinopathy and nephropathy. So the different patterns, important actually to keep in mind, the different patterns, of damage seen in peripheral neuropathies in diabetics that include monopathy. And the most common, is symmetrical sensory motor neuropathy, which may cause pain, sensory loss, sleep, disorder, absent tendon reflexes, and weakness. So the most likely pathological type of the neuropathy seen in diabetics is axonal loss. In some cases, demyelination may also happen, and the small axons are more affected than the large axons. All right. So the underlying mechanism of diabetic neuropathy, have many pathways. Prominent among these pathways is ischemia due to microvascular changes. All right, so now this is a polyarthritis nodosa. And here you see in the top picture the fibrinoid necrosis of a small artery in a patient with this condition. And the arterial wall is completely necrotic. And you can see the reaction from the, from the surrounding area with this very, strong inflammatory infiltrate surrounding, the escaping plasma, proteins from the vessels into the surrounding regions. Now, the bottom picture shows here a large area of nerve fiber replaced with collagen due to ischemia secondary to vasculitis. So this is from a patient with PAN with polyarthritis nodosa. So the top picture shows in and prevascular inflammatory infiltrate resulting in a destruction of that vessel completely. After a while, the vessel wall is opening up, the vessel will be no more. And the nerve that is supplied, let's say that this is the nerve supplied by this vessel, is going to be affected. There is going to be demyelination, as you can see here, and there will be a lot of collagen that is getting deposited, so there will be fibrosis. There are a few in between, myelin fibers that are still there. Finally, the Guillain-Barré syndrome. So in this case, you see heavy perivenular lymphocytosis with associated, degenerative changes. In the bottom picture, you're going to see what you call the temporal heterogeneity that you see in this condition. So you're going to be seeing different stages of damage and healing. We talked about this. So top left corner, you're seeing, demyelination. Top right corner, you see myelination in progress. The bottom left corner, you're seeing thick ring-like myelin sheaths surround a fully healed or never affected nerve fiber. Okay, so with Guillain-Barré, this is what you're going to be seeing here, the perivenular lymphocytosis, type of inflammation happening in the spinal root and peripheral nerves. Right, so the most common, this is the GBS, the most common demyelinating neuropathy. Rare, but when it is presenting, it's usually catastrophic. It's a medical emergency. Proper diagnosis may save lives. How does it present? Usually presenting with paresthesia at the fingertips and toes, and then it advances centrally within weeks of onset. After which recovery hopefully will happen. Of course, the recovery, if you have saved the patient's life by supporting the respiratory system meanwhile. So at the peak of this disease, the patients may be completely paralyzed and unable to breathe. So the nerve conduction are going to show the decreased conduction or complete block of conduction, similar to what we have seen, what we have talked about before with demyelination. Now you do the CSF studies, and you see high protein without pleocytosis, without cellular, without the inflammatory cells, what is known as albuminocytologic dissociation. Some of the cases of GBS, are going to be preceded by an infection. So this is important to elicit during your examination of the patient, in the history of the patient, about a recent infection, such as the Campylobacter, Mycoplasma, or cytomegalovirus. So some people feel that there is a molecular mimicry, mechanism that exists between the pathogen and component of the myelin sheath, resulting in an attack on the myelin sheath. All right, that's it. All right, guys.
تمام، يعطيك العافية دكتور.